Hey everybody, welcome to our class via PowerPoint and narrated by me. I wanted to thank you all for listening today. And just to do some housekeeping stuff, if you want to follow along, most of this material is coming from Lenny's chapter 28 and 29, and then Porth chapter 49 we had started to already talk about for pain management, but feel free to go back into that chapter as well, look at the different definitions of pain, so just to know where this is coming from, I wanted to let you know. Alright, so let's dive into pain management, and especially we're going to touch on pain management at the end of life, because I think that's a really important area. Alright, so we're going to start with differentiating between nociceptive pain and neuropathic pain. So nociceptive pain is the most common type of pain that our patients will experience, and this happens as a result of tissue injury. This can happen from various disease states such as cancer or trauma. Also, it can happen because of inflammation. So let's have a quick review. What happens to our vessels when they're inflamed? You all said vasodilation, right? Good work. So vasodilation. And then the rush of all of the mediators to help to decrease that inflammation is what causes the patient pain. So the other thing I want to just clarify here, nociceptive pain has two forms, somatic or visceral. And somatic pain is pain in the muscles or the joints, and visceral pain is pain in the internal organs, especially of the gut. So if a patient has hepatitis, I had said they can have liver pain. That would be visceral pain. So then let's contrast that to neuropathic pain. Neuropathic pain is when we have damage to our nervous tissues. And something to remember here is that the pain medications, opioids, will not work to treat neuropathic pain. Neuropathic pain does not respond well to opiates. So what can we use for them? Well, we can use for them alternative therapies. So those alternative therapies are massage therapy, guided imagery. And then the other thing that works well is we're going to chat about a category of medications called adjuvant medications. And an example of an adjuvant medication is something called, is our category of medications, tricyclic antidepressants, specifically amitriptyline, which is Elavil. So amitriptyline, even though it's a tricyclic antidepressant, works well with neuropathic pain. So opioids do not work well for neuropathic pain. The other thing that I just want to go back to for nociceptive pain. So for nociceptive pain, we certainly can use opioids. That works well for them. Before we go straight to an opioid, we'd like to try to use something a little bit less invasive. So what would that be? That would be an NSAID, like aspirin, or a COX-2 inhibitor. And we're going to go through, if that doesn't work, moving up toward opioids. Okay. So, how do we manage a patient's pain? I think that it's really laid out well here for you guys, but really let's start with the top. So you want to assess your patient really systematically and regularly. You want to ask about pain every time you're getting a set of vitals. You want to also believe the patient when they tell you that they're experiencing pain, and to remember that pain is what the patient says it is. And I think as new nurses, we do a really great job of advocating for our patients and saying, okay, Mr. Jones that just, had surgery, he's in pain, we're going to medicate him. Whereas sometimes once people have been practicing for a while, and this is a generalization, but we start to say, oh, well, that surgery doesn't cause that much pain. They can't be that uncomfortable. I really want to caution us not to do that no matter how long we've been in practice, right? Pain is individual to each patient. I had touched on the fact that I think that, everyone has a different pain tolerance, so keep that in mind throughout your career for sure. So then the other thing is that you want to make sure that you choose the pain management medication that's appropriate for that setting that the patient is in. So meaning if they're going home in hospice care, or they're going, home to a nursing, or going to a nursing home, or home to their actual house, you're not going to send them home on IV medications. You're going to send them home on PO. That being said, if they can't swallow, you're going to make sure that they can take something sublingual. So just be really cautious you're picking the right method, or that the prescriber, in conjunction with you, is picking the right method. All right. The other thing here is to make sure that your interventions, your pain medication, is given really in a logical, timely fashion. Now, so what do I mean by that? So say Mr. Jones, let's go back to him, is having a dressing change. Say he has a pressure ulcer, and his dressing change is scheduled for 10 o'clock in the morning. And you know you have 5 other patients that need meds passed. You're going to make sure that Mr. Jones gets his medication at least 30 minutes before his dressing change. Why would that be important? So for those of you who are thinking about it, right, that medication you want on board and starting to work. If you hand him the pill and then do the dressing change all in the same 5 minutes, he's going to get no relief, and that dressing change is going to be unnecessarily more uncomfortable. So make sure that you give that medication, your opioid, at least 30 minutes before a painful procedure. All right, the other thing is to make sure that the patient's empowered, that they know that it's okay to ask for pain meds. Don't make them feel that they're seeking by asking. So share with them, I want to know when you're uncomfortable, and when you're uncomfortable early on, not when it gets too bad, so that we can make you comfortable. So give patients permission to ask for their medication. The other thing is to make sure your patient and their family understand what the side effects of the medication are, what medication they're actually getting, and how this medication works. The other thing that's a good thing to do is tell the patient how long the medication will work for, how long it will work for, how long it's about roughly going to take for them to feel better. I think that the more we inform our patients, the more that we're able to decrease their fear. And so let's just play out that scenario. When we're scared, right, when we're scared, things become more painful. So if we explain things to a patient, we can decrease their fear. And if we decrease their fear, right, we're hopefully then decreasing their pain as well. All right, and then the last thing is keep evaluating your patient about their pain. So you gave your pain med to Mr. Jones, right, at 9:30 or 9 o'clock, right before his 10 o'clock dressing change. You want to go back in there about a half an hour to an hour after you gave the pain medication and say, hey, Mr. Jones, how are you feeling? Because if he's not feeling any better, then you want to talk to the prescriber, go back to square one, and make sure that you contact that prescriber, advocate for your patient, and get another pain medication. All right, so that's really important to remember. So how do we assess pain? I just talked about this on the last slide that it's important to do, but there may be some of you who are wondering, well, how do I assess a patient? So what we're going to do is go through a really systematic format for pain assessment. I like the mnemonic OLD CARTS, okay? So OLD CARTS stands for onset, location, duration, character, alleviating or aggravating factors, radiation, so does the pain radiate, the pattern, the temporal pattern of the pain, and the severity of the pain. So when you're assessing a pain of a patient, and then you call the provider to report this pain, they're not going to want to just know, hey, Mr. Jones is in pain. They're going to want you to say, Mr. Jones started having pain 2 hours ago in his abdomen. It's lasted the full 2 hours. It has not let up. It's a sharp pain. It's been slightly alleviated by position changes, but it's really been aggravated if he goes for a walk. So just position changes in bed have helped, but walking is aggravating it. It doesn't radiate anywhere. It doesn't really have a pattern yet because it's only been there for 2 hours. And he's rating his pain as a 5 out of 10 on the pain scale. So that would be a really succinct way to report to a provider a patient's pain. So you want to make sure you're assessing all of those things. I have written on the bottom here previous treatment and impact on ADLs. So you want to know if the patient has had pain like this before, ask Mr. Jones, well, what's worked for you in the past? Because clearly if something's worked, we're going to go for that. And then if this is pain that's been ongoing, you want to know if it's affecting their activities of daily living, okay? All right, so what I have here is the numeric pain scale. This is just linear pain intensity scale. This is taken straight from your Lenny book. Most hospitals will have this out for patients so that patients can go ahead and rate their pain. Most hospitals, to be JCAHO compliant, actually, like I said, have this pain scale on a whiteboard with the nurse's name so that as the vital signs are being taken and the patient's being asked about their pain, they have this visual in front of them. of no pain, moderate pain, or worst pain possible. So you would ask your patient, on a scale of 0 to 10, where would you rate your pain, with 0 being no pain and 10 being the worst possible pain you've ever experienced. So the FACES, this is the Wong-Baker FACES pain rating scale. Who do you guys think this is used for? If you've answered children, then you're correct, right? Because 0 to 10 might be a little bit hard for children. So for kids, what we can do is we can show them these FACES. I'm sorry, the slides are advancing on their own. I can't help that, so I'm going to just keep going back with them. So when you have a pediatric patient, if you show them these FACES, you can say, this patient that has no hurt, that's a 0, is really happy playing. And then this patient that's crying is upset because he or she is not comfortable. And you show me and point to which face you are feeling. And this really has been validated in children to work well. And again, you have them point to what they think they feel like. Okay, so this Abbey Pain Scale, what this is used for is for patients who are cognitively impaired. So if you think back to our Alzheimer's patient, if they're in an advanced Alzheimer's state, it's going to be hard to assess them for pain. So we want to make sure that we're looking at their vocalization, so not looking at, I should use the word assessing. So if you're the nurse caring for an Alzheimer's patient, you are going to use this pain scale to assess what their pain level is if they are a nonverbal patient. So you're going to say, are they whimpering, groaning, crying? What's their facial expression? Are they grimacing? Do they have a change in their body language, their posture? Is their behavior changing? Are they more agitated? Are they not eating? Has their blood pressure gone up? An important thing here, right, is that elderly patients can be on medications to lower their blood pressure, right? So if they're hypertensive and they're on a blood pressure lowering medication, they're not going to show that physiological sign of an increase of blood pressure when they're uncomfortable. So just don't always rely on blood pressure, especially if your patient is on blood pressure medication. Okay, so aside from physiological changes, you want to look at the physical changes too. So is the patient experiencing pressure ulcers or skin tears? And again, our patients who are nonverbal tend to not necessarily be medicated as well as they should be because they're overlooked. They're not asking for pain meds, right? The squeaky wheel gets the grease, and in this case, if this patient isn't verbalizing that they're uncomfortable, they can be overlooked. So we want to make sure that we're not doing that. The other thing is if there's no family advocate for the patient, they're more likely to not be getting the pain medications they want. So we want to keep them in our radar if we have patients that are nonverbal in our care. Okay, so for the ongoing assessment or evaluation of pain, I had touched on the fact that once you give your pain medication, within a half an hour to an hour, you want to walk back into that room, see how your patient's doing, make sure the pain medication worked, and if it hasn't, you want to contact the provider. Okay, so let's go for this question. I'll give you guys a second to read it. So MS Cotton is OxyContin. All right, so I hope that everyone here has chosen that we're going to contact the prescriber to get an order for an increased dose. So let's talk about why that's the case and why that's the best answer. So let's break apart the question. The patient has OxyContin, that's MS Cotton, ordered for them, and they're reporting their pain to be a 9 out of 10. That is extremely high, that pain score. So the patient had a dose at 9 a.m. and it's now 2 p.m. So that dose was 5 hours ago, right? And now they want more medication. Most pain medication is given about every 4 to 6 hours. So they're right in that range, okay? So let's say that this medication is due every 6 hours. The patient's about an hour away from their pain med. So what are you going to do? You don't want to just wait and tell the patient A. That's definitely not the right answer. To tell them they're not yet due for pain meds, you need to wait an hour. If your patient's reporting a 9 out of 10, you cannot pick A. So how about B, employ a non-pharmacological method of pain relief, such as a back rub or cold compress. I would argue that that's lovely to do, but when a patient has a pain of 9 out of 10, that's not going to touch their pain. I would get them medicated and then offer them something like